you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Edlyn Rodarte, and I am the Virtual Program Associate at CSCLA. I welcome you to this week's webinar titled Fertility and Cancer. Today we are joined by Dr. Lindsay Kroener to review how cancer itself, as well as cancer treatments, can affect fertility in both women and men. Options for fertility preservations will be discussed, as well as how fertility treatment can impact cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I'd like to welcome today's speaker. Dr. Lindsay Kroener is an assistant clinical professor at UCLA Geffen School of Medicine. She is a double board certified in Obstetrics and Gynecology and Reproductive Endocrinology and Infertility. She completed medical school at the USC Keck School of Medicine and went on to complete her residency and fellowship at UCLA, where she stayed on as faculty. She serves as the Associate Program Director for the UCLA REI Fellowship Program and is very involved in medical school, medical student, resident, and fellow education. Welcome, Dr. Kroener. We're so honored to be hosting you today.
This is a big topic. This could be many hours of discussion, so I'm just going to try to kind of briefly talk about some of the most pertinent parts of this. Obviously, all of this is individualized as well. One second. I have no financial disclosures. So the objectives of my talk today are, one, to discuss how cancer and cancer treatment can affect fertility in both men and women. I see women more specifically. I'm an OBGYN, but men are part of the other half of this too in terms of fertility. So we'll make sure we address that as well. We're going to talk about how and when to assess fertility post-treatment. We're also going to review some fertility preservation options. A lot of this is, often addressed prior to treatment, but I think still very pertinent to review here. And some of these options are actually available post-treatment and in survivors as well. And then treatment options after cancer treatment. And then I'm briefly going to talk about preimplantation genetic testing to screen embryos for cancer-causing mutations. We've learned a lot more about genetics over time and in relation to cancer. And, there are ways to kind of think about, how we can minimize this risk in future generations. So I think an important thing to briefly touch on. And then lastly, how cancer may affect future pregnancy. All right, so scope of the issue, and I think many of you are aware of all of this, but invasive cancer is diagnosed in 1 in 48 females before the age of 40. Survival rates are high and continue to improve, which is great. That also means we have a lot of cancer survivors to kind of manage fertility issues. Childhood cancers have over 80% survival rates, and then breast cancer survival is about 90%. So there's about 380,000 women of reproductive age that are cancer survivors. And I only mention women specifically here just because age is an even bigger factor. Of course, age can affect fertility for both men and women, but especially with women, this is very important. So improving, cancer survivor rates. So here's some data from the American Cancer Society, basically comparing survivorship from the 1970s through the 2000s. And obviously this is continuing to improve. And if you look at this sort of bar graph here, you can see some of the most common types of cancer, such as breast cancer. You can really see there's significant improvements in survivorship. So obviously there's more patients who are going to be, at risk for cancer-related infertility. So scope of the issue. So we know that female cancer survivors have an increased risk of infertility. They're also at higher risk for premature ovarian insufficiency and early menopause. So not having periods either for a brief amount of time or in a prolonged fashion. We'll talk about some of the risk factors for that. And then also adverse pregnancy outcomes. Many people with a history of cancer have future children, but there are some increased pregnancy outcome risks that I think are important to be aware of. Both males and females who undergo cancer treatment are about 80% more likely to have diminished fertility. There are people with lower fertility that still get pregnant, but I think it's important to be sort of more proactive, after treatment and thinking about how to move forward. And unfortunately, we really lack good tools to accurately predict the chance and timing of infertility. And this isn't just true in a cancer setting. I mean, this is true for all comers. People come to my office all the time asking me to predict their future fertility for a variety of reasons. And we have some limited tools, but ultimately, on an individual basis, we don't know for sure most of the time. And then, future fertility and survivorship. So kind of continuing along these lines, fertility preservation methods are really effective. And I think, access to care can be a huge issue here. Cost and lack of coverage are major issues that I think as a specialty we're trying to address. But there's been a big emphasis that healthcare providers should really be addressing, one, the possibility of infertility related to cancer treatments, especially, in patients in their reproductive years. This is really considered to be a measure of quality of care in oncologic care. And so I'm hopeful that most of you have had this addressed if it's related to you personally. And as a medical field, I think we need to aim to really improve counseling and access to these services, both before and afterward. And I know, at the time of a new diagnosis, it's a very overwhelming time. So it's hard to address all of these things at that time when there's so much else going on. But I do think as much as we can, trying to provide this information is important. And then fertility counseling recommendations sort of along these lines, again, just addressing the impact of, cancer treatment on future fertility. And a number of societies support this, starting in 2006, ASCO, or the American Society for Clinical Oncology, came out the recommendation as part of education and informed consent before cancer therapy. Oncologists should address the possibility of infertility in patients treated during their reproductive years and prepare to discuss possible treatment options or refer to a reproductive specialist. And I think even, thinking about this during treatment, if it's a lot initially or even sort of early in the survivorship sort of path, I think that these are important discussions, to have. So I'm going to start just by talking about the impact of cancer and cancer treatment on fertility. So I think in order to understand how cancer treatment can impact fertility, it's really important to understand, normal ovarian function and just how things work in a normal setting. So these pictures over here, you see the picture of an ovary here. It actually has the different phases of an egg being released and a fallopian tube. And then on the bottom is basically an ultrasound image of an ovary. And this is what I look at many, many times a day. I always like to describe the ovary. So this ovary kind of looks like a chocolate chip cookie and all these little black circles of follicles, and they hold eggs. As women, we're born with all the eggs we're going to have. So actually at 20 weeks in utero, we have about 10 million eggs. Even by the time we're born, that goes down to about 1 million. And then that number slowly decreases up until the age of menopause, which can vary. The average age is 51. And basically the oocytes decrease over time, whether you're releasing them or not, and they don't get replenished. And the ovary is very sensitive to damage, so from chemotherapy, radiation, other types of treatments. So that's kind of, quantity of eggs is sort of looking at these little chocolate chips, so to speak, in the ovary, and looking at the sort of the number of follicles. Egg quality is really related to age, and that sort of plays a big role in a lot of the things we're going to talk about. Quality really, there's no magic age where quality goes down, but we know it's a spectrum over time. And, we consider 35 sort of advanced reproductive age, but nothing magic happens then. I think just knowing that sort of the chance of an egg resulting in a live birth goes down as people get older and there's a higher risk of miscarriage and things like that. So normal ovulation. So one other component of this is kind of understanding, each month, basically your brain actually controls ovulation. So when you get a regular period, it means that you're releasing an egg each month. So typically what happens is these structures in your brain release hormones. The typical hormones that make you release an egg each month are LH and FSH. FSH is follicle stimulating hormone. And basically your brain releases FSH, and that's going to make one of these follicles grow. So in that first picture I showed you an ovary that had lots of little black circles. Here you see that there's one bigger black circle. That's a follicle that holds an egg. And the brain actually controls that to grow and then to be released. So those hormones are released, you grow that follicle and you release that each month. If you don't get pregnant, you get a period. And so that's kind of the normal cycling that happens. So there's ways we can assess the quantity of eggs in the ovary, and this is called ovarian reserve. Ovarian reserve doesn't predict your chance of getting pregnant, but it does predict, let's say you were going to do fertility preservation, you were going to freeze eggs. How many eggs could you freeze? That really relates to sort of your ovarian reserve, or how many eggs are resting there in a single cycle. And there's a few ways to measure ovarian reserve. These are things that we use all the time. So the three main ways to look at reserve are, one is something called antral follicle count. Again, it's basically counting these little resting follicles, or so to speak, chocolate chips in the ovary. A second way to look at ovarian reserve is to look at labs sort of early in the cycle, looking at estrogen and FSH, which is that hormone I said was released by the brain. What we can see is sometimes if that FSH level gets high, it tells me basically that the brain is working really hard to try to stimulate the ovary, but the ovary isn't responding the way we want it to. So, in people who are, in menopause, we can see very high FSH levels. That tends to be when things are kind of getting much lower. And then there's AMH, or anti-Müllerian hormone. And this is a single blood test that basically gives me an idea of resting follicle count. And so a lower AMH is more consistent with low reserve. And these are the most common things you'll see utilized to sort of look at egg quantity. So then kind of getting to how cancer treatment can affect fertility in women. So, common treatments include gonatotoxic treatments. Like I said, the ovary is very sensitive to any sort of damage from chemotherapy and radiation. And this can affect the ovary and the quantity of eggs. It can also impact the uterus. You think of it more affecting the eggs and the ovary, but certain types of treatment can affect the uterus and sort of the blood flow there. And then even the brain structures that control ovulation. So for instance, radiation of the brain can affect those brain structures that allow you to even release an egg. So those are a couple of the mechanisms. And then in terms of surgical management, so especially surgical management of gynecologic cancers, right? So like uterine cancer, cervical cancer, ovarian cancer, removal of any reproductive organs or portions of those can have an impact on fertility. So removal of a portion of the cervix, the uterus, the fallopian tubes, the ovaries. We have a lot of things at our disposal to sort of help and offer a variety of paths to parenthood, but these are other mechanisms that can are ways that cancer can impact fertility. So other things, recommendations for longer durations of treatment or adjuvant treatments. For instance, initial treatment for breast cancer might be done, but there may be a recommendation to continue tamoxifen for 5 or 10 years, following the completion of chemotherapy and or radiation. So definitely that time delay can have an impact. When is it safe to stop that? Also concern for hormone exposure to certain types of tumors, especially those that are sensitive to estrogen, right? So breast cancer can be sensitive to estrogen. Estrogen goes up during fertility treatment and during pregnancy. So these can definitely be concerns. And then just delay in treatment, right? So if there's a need to wait for a certain amount of time in remission before considering pregnancy, that can be an issue because egg quality changes with age. And then mechanisms, I mean, I think I touched on this, but basically chemotherapy works by affecting cell division, right? You want to target these rapidly dividing cells that are causing an issue. That being said, normal cells, as you know, from side effects of treatments, normal cells are going to be affected, and the ovary and testicle are cells that are easily affected. This can affect the eggs themselves and also the cells that support the eggs, which are essential for function of the ovary. And then radiation treatment, a lot of this sort of can impact not only these sensitive cells, but it can even impact, like I said, the blood supply to the uterus or the muscle itself. Okay, so impact of chemotherapy. So a big part of this is, you want to predict, well, how is this going to affect me? And what is it going to look like after I'm done with treatment? The type, the dose, and the duration of chemotherapy are clearly key in determining this, and also individual baseline factors. So the age at the time of treatment, if you're 14, that you're going to need a lot more chemo or radiation to have a negative impact than if you're 40, because that baseline reserve is going to be lower as you get older. And then how can you assess this? So looking at what happens to menstrual cycles, when the menstrual cycle stops, that's a sign that, there's some sort of damage happening. And then also looking at those reserve markers that we talked about. I think it's important to note that it's very common to acutely stop getting periods during treatment. And a lot of people are going to resume periods again later. And we'll talk about the timing of this, but that acute change is extremely common. And that sort of part of the question is, well, is function going to resume? And if it's going to, when is that going to happen? And I don't want you to get bogged down in the details of this chart, but I think it's important to know that there's a lot of different guidelines about what different types or how different types of chemotherapy can impact the ovary. And so this is a chart from Livestrong that I like, and it kind of breaks things down into high risk, which is about 80% chance of not getting periods post-treatment, intermediate risk, which is about a 30 to 70% of amenorrhea or not resuming periods, and then low risk, less than 20%. And then this is a chart that sort of talks about some of the higher risk chemotherapy. So I won't get into this too much, but I think it's important to know there's lots of good resources for this. And this is a discussion to have with your oncologist, specifically rated sort of your baseline, what type of treatment you had, dose, all of these things are going to play into that. Ultimately, when I have someone come into my office, it's impossible for me to predict, but I know, for instance, if someone's young and it's a low risk type of chemotherapy, I feel much more reassured than maybe someone older who had a higher risk type of chemotherapy or radiation. Okay, so just switching over to men a little bit here. So normal production of sperm. So what happens? Sperm develop in these seminiferous tubules, so these little tubules in the testicle. It takes about 3 months from the beginning of a little germ cell for a mature spermatozoa to develop. So we kind of think of the life cycle of sperm as being about 90 days. The sperm are then stored in this epididymis and then released at the time of ejaculation. Like the ovary, the testicle is very sensitive to damage. And a semen analysis is the best sort of baseline way to assess sperm. So, and that's, obviously easier to do than, some of the things we have to do for women. But again, probably the best way to initially assess things. So then kind of addressing the same question for men, how can cancer treatment affect fertility in men? So again, gonatotoxic treatment, so chemotherapy and radiation, testicular function can be impacted, right? So this is those seminiferous tubules and the actual germ cells that become sperm, and then testosterone production. So there are these supporting cells in the testicle that need to produce testosterone for sperm production to happen. All of those cells are sensitive. And then just like I talked about in women, the brain structures that release hormones to make you release an egg, men release those same hormones, and that's what allows for production of sperm. And then surgery involving the reproductive organs. Again, so the testicles, the prostate, any other reproductive organs. Not only can this directly impact sperm production, for instance, a testicle is removed, but also impacts on sort of libido, erectile function. There's obviously that requires appropriate nerve function. And so that can be impacted with, prostate cancer, for instance. And then sort of timing of chemotherapy exposure and sperm. So I think similar types of treatment tend to affect men and women. The impact on, and these can impact sperm, not only the quantity, but also sort of the integrity of the DNA in the sperm. I do think it's important to note that no studies have shown an increase in sort of congenital anomalies or birth defects in pregnancies resulting from sperm that was exposed to treatment. Timing of exposure to chemotherapy and radiation may be important. And so I don't want to harp on this, but obviously different things are happening in the testicle at different stages, right? So if someone's pre-pubertal versus during puberty versus later, impacts on sperm can vary. And the only reason I put this little chart up is here, you can kind of look at the risk of fertility after on fertility after adulthood exposure and here in childhood exposure. And you can see there's some variability in how these different treatments may affect sperm. Okay, so how and when to assess fertility post-treatment? So let's start with women here. So assessing ovarian function. So one, you're looking at resumption or, return of menstrual cycles. Like I talked about, very common, even in less gonatotoxic or less toxic types of treatment, to stop getting periods initially during chemotherapy. You can look at serial ovarian reserve markers. So those same markers I talked about before, looking at FSH levels, AMH or anti-Müllerian hormone, and then looking at, kind of the reserve or resting follicle count in the ovary. And these can be assessed over time. So I think the big questions are, when would you expect to see if the ovary will recover from treatment? And if menstrual cycles resume, what does that tell me about fertility? Because those aren't one and the same. Cycles can resume, but there can still be lower egg quantity. So timing of recovery. So again, like I talked about, amenorrhea or no periods, it's very common to have that post-cancer treatment. It may take months to years for menses or periods to resume. Most women will resume their periods within 2 years if they're going to resume periods at all. Again, age, type of treatment, and baseline markers are going to be your best predictors of that. And it's true, like I kind of mentioned before, periods can resume, but reserve can still be low. And so these, if that's the case, women may be at risk for earlier menopause. Unfortunately, we're not good at predicting when that's going to happen. But I think if we say, hey, periods have resumed, but the reserve or the quantity of eggs looks lower, I think these are all reasons to really try to expedite, using the eggs that are there. And sort of expediting treatment or trying to get pregnant at that time. And again, lacking good tools to predict early menopause or really to know what future fertility looks like. I thought this was an interesting study. So again, resumption of menses doesn't really tell me about, predict fertility, but I think it's a good marker to at least have an idea of the function of the ovary. This was a study looking at breast cancer patients, and actually 97% had amenorrhea during chemotherapy. For women under 30, all of them resumed periods within a year. Of patients less than 39, about 50%, or sorry, there should be a percentage there. Most of these resumed periods, but all that were over 50 stopped having periods. So again, I think that the younger you are, the more quickly you're going to resume periods. So it was within a year for those less than 30. It may take longer if you're older. And if you're in a even older age range than that, it's more likely that, you will not resume periods. Women who are 35 or older took greater than 2 to 3 years. So it may take longer, but the majority of women, I would say, I usually tell people within 2 years is sort of a good marker to have an idea of what's going on. Some people it's going to be much faster, and there are people who are going to be outside that most common time frame. So then kind of turning this over to men here. So post-treatment assessment in men. Again, looking at semen analysis is going to be a first line option. And then also looking at some endocrine factors or looking at some blood work. So looking at some of these hormone levels, so FSH and LH that I've talked about that are released from the brain, also estrogen and testosterone. If the sperm count's low, often we'll look at these endocrine markers, and sometimes we can see abnormalities there as well. So what about the timing of sperm improvement post-treatment? it really, again, it depends on the type of treatment, and it's highly variable in terms of recovery. It may take 1 to several years for sperm to recover. So we think of a sperm life cycle I talked about as about 3 months. And so some studies suggest waiting at least a couple of cycles, so maybe about a year in many cases, to see what the sperm's going to do. Let's see, some men may have no sperm recovery. I know there's one study looking at men with specific types of cancer, and it found about 60% did not recover sperm counts, but many men do. So those are kind of basics there. And I know it's vague. Everything is really patient specific, as all treatment, but I think it's good to at least have an overview. And I think, having an idea of baseline and sort of specific treatments to an individual is helpful. So let's touch now on some fertility preservation options, and then also, fertility treatment options, post-cancer treatment. Okay, so here's some fertility preservation options. So there's a lot to talk about here, and I'll try to not get too bogged down in the details. Standard of care, if you think about fertility preservation, it's either freezing eggs or embryos, and I'll talk about that in a little bit of detail. That's something that can be done prior to treatment, or it can be done after treatment, thinking about family size. Let's say you have recovery of the ovaries, but wow, you're 38 and you're really wanting to have multiple kids. This is something that can be done after treatment too, assuming that, there's eggs there to freeze at that time. Other things like gonadal shielding is sort of blocking the ovaries when you're getting radiation, moving the ovaries surgically out of the radiation field, or surgeries that leave in reproductive organs. So again, I won't go into those too much. And then there are some experimental methods. And I think these are interesting because these are things that you hear about that we don't use as much, or are not as effective as egg or embryo freezing, but I do think there are things you'll hear about. One is sort of suppressing those ovaries with a shot that's actually very commonly given in women prior to lots of types of chemotherapy, called a GnRH agonist. It basically puts someone into a medical menopause. And there's some sort of minimal data that can be beneficial. Again, that's a pre-treatment, something or during treatment that's often done. And then banking of ovarian tissue. So can I take this piece of my ovary and freeze it and save it for later? And I'll just briefly touch on that. Again, those are experimental things. So egg and embryo cryopreservation. So ovarian stimulation and in vitro fertilization. I'm just going to put these pictures up here. Okay, so what is IVF? It's basically combining multiple cycles of trying into one cycle. So what do? We give injectable forms of medications, and they're injectable forms of FSH and LH. So those same hormones that I showed that were released by the brain, you take those in subcutaneous injections for about 8 to 12 days. The goal here is to get multiple follicles to grow in the ovary. So if you remember that first picture I showed you with all the little follicles here, now you can see lots of these follicles are big. So basically, we're trying to mature multiple follicles at once. Then what we can do is actually sort of trigger ovulation with a little shot, but before the eggs are released and when they're mature, we go in and do an egg retrieval. And that's what this picture is down here. We basically take an ultrasound probe. There's a little needle that kind of goes through the vagina into the ovary, and this little needle suctions out the fluid in all of these follicles. Typically from the bigger follicles, you get an egg, and then we can take those eggs, and I'll talk to you about the options. We can either freeze them or make them into embryos. So egg freezing, right? So what's the difference? So in egg freezing, you're just going to take the eggs and you're going to freeze them. So let's say, you want to save your eggs, but you don't have a partner you want to fertilize the eggs with yet. This is a really good option. So you basically can take a little oocyte that we have here, and you can freeze it with a rapid freezing technique. It's something called vitrification. And this is really what lets us do this, because about 90% of these eggs are going to survive after they're thawed. And it gives you, gives options here. Now, in order to ever use these eggs, they need to be fertilized and grown out into embryos. So this is kind of one option. Then the other option is just to make them into embryos up front. So that's where you take these eggs and you fertilize them in a dish. And as you can see, you're starting with one cell here, and then it's starting to divide. You grow this for about 5 to 6 days until it becomes an embryo called a blastocyst. This is about 100 cells. This little part here is actually the inner cell mass. That's what becomes the baby. And then these outer cells become the placenta. And then these can be, these can be frozen, and then they can be put back one at a time. So even thinking about future, babies down the road. And basically you put them back in the uterus. They can even be put into a gestational carrier. Let's say there was an issue with the uterus, or maybe, it was felt to be unsafe for you to carry a pregnancy. So there's lots of options here with embryos. The nice thing is, as I tell all my patients, there's no shelf life on these. Once they're frozen, this freezing process really stops all biologic processes. So it gives flexibility if we're able to do this. So safety considerations, I think that this is really important, right? You've gone through all this treatment. How is this going to affect me? Is this going to negatively impact, safety of my cancer treatment, or, what my prognosis is going to be? So one thing is, when you think about doing this from a preservation standpoint, is this going to delay my treatment? IVF stimulation can start at any time in the menstrual cycle, and it will really be completed within 2 weeks. So really, in almost all cases, unless, there are certain circumstances where, chemotherapy needs to start within 2 or 3 days. And those are scenarios where it's not safe. But I do think the vast majority of scenarios, we are able to do this. And there have been some studies in breast cancer patients that have shown no difference in complete pathologic response or 5-year disease-free progression between those patients who did and did not do fertility preservation. High estrogen levels. So I alluded to this kind of before, but one thing that I always tell patients, we never know 100% what the treatment is going to do. However, there are medicines that we can give during a stimulation to keep estrogen levels low. Estrogen levels in an IVF cycle can get really high. And this is something to think about, either prior to treatment, or let's say in a breast cancer patient after treatment. Like, wow, I have eggs in my ovaries, but is this going to have some negative impact on me? And a lot of times we give people a medication called letrozole to keep estrogen low. It's also a very short duration of elevated estrogen. And what I tell people is the levels that you have during pregnancy are going to be high for a much more sustained amount of time. So, I think overall the data here doesn't seem to show that there's a worse prognosis of cancer, but I think these are things to really be aware of. And then a couple of experimental methods that I just want to touch on a little bit here. So ovarian tissue cryopreservation. So this is basically excising a part or the whole ovary. And this has to really be done prior to treatment. So, egg or embryo freezing, that can be done before or after treatment. Again, depends on, sort of the impact of the chemotherapy, but it's possible to do it in both scenarios. We really wouldn't do this post-treatment. And basically the idea is that this is frozen. So then down the road, this can basically be transplanted or put back into the body in order to potentially even have a spontaneous pregnancy. So this picture actually is little strips of previously frozen ovary that was then transplanted back into the original area of the ovary. One of the concerns with this is concern for reintroduction of cancer cells, right? So if you took out this tissue prior to treating cancers, there's some worry that there could be some cancer cells in that tissue you're putting back into the body. And then, this is, again, it's experimental. So this is not done that much. There's certain scenarios where it may be more applicable. So, in girls or prepubertal girls who have not had periods yet, and we couldn't freeze eggs or embryos, but there's only about 87 births worldwide that have been reported here. I'm sure this number is growing because, these are from kind of 2018, 17. So, and then ovarian suppression with GnRH agonists. And I think this is used for a number of reasons in the setting of chemotherapy, especially if there's worry about, blood counts going down and bleeding risk. So this is something that, some of you may have gotten. And basically, like I discussed a little bit before, it's a shot that you can get once a month. It essentially puts you into a medical menopause. So it makes the ovaries really quiet, essentially, and makes hormones not be produced by the ovaries. You're also not releasing an egg when that's happening. There is a little limited data that shows that if people get this shot during chemotherapy, they have a higher chance of their periods coming back. So a lower chance of amenorrhea. And then there's a little bit of data that there could be some improvement in future fertility, but again, this is very limited. So I think, the recommendations in general are that this can be offered to patients. And I think the important thing to remember about this is that it should not replace traditional methods. It's not as effective and it doesn't work as well, but can it be a useful adjuvant or something to consider? Absolutely. And anytime I'm talking to patients, I absolutely discuss this as an option, but I think just important to understand that it's not the equivalent of egg or embryo cryopreservation. Okay, so what are post-treatment options? So your treatment is complete. You're clear, your oncologist feels like it's okay to move forward with pregnancy. What are the options and what should you do next? So one, consider natural conception. I think always a good idea to go see an OBGYN, come see a reproductive and endocrinologist at that point and get an assessment, get an idea of what ovarian reserve looks like for you, really monitor your cycles. But trying on your own is definitely an option here. And I think, age, reserve, all of those things are gonna help to dictate what makes sense. There are also, treatments where we can give people either pills or shots to get you to release more than one egg. And then pair that with an insemination. And an insemination is where you take sperm, you wash it, and you put it in the uterus right at the time of ovulation. So these are treatments that we do in all women with infertility. And if there's eggs in the ovaries and we're sort of trying to expedite pregnancy, these are definitely options. Then doing IVF. So like I said, sort of doing that whole IVF process, but doing that, after treatment. Usually we don't like to do an IVF cycle within 6 months of chemotherapy. There's no hard and fast rule, but often there's going to be less response. And I think just some concerns in that time frame about sort of egg quality and things like that. But doing IVF post-treatment. There's also the option of using previously frozen eggs or embryos for transfer into the uterus. So I think part of this depends on, what's your age at the end of treatment and when you're trying to get pregnant. Let's say you have frozen eggs from age 35 and you're 43, likely thinking about using those frozen eggs or embryos is going to make a lot of sense. Let's say you're younger and the reserve looks good, then maybe save those in case it doesn't work on your own or maybe for another baby down the road. And then, of course, there's sort of alternate options. So different ways of building families that are sort of, sorry, my desk just moved, that are different from the things we think of traditionally. So considering using a gestational carrier or a gestational surrogate. So this would basically be taking embryos that were made with your eggs and partner sperm or sperm of choice and basically putting them back into the uterus of someone who can carry this pregnancy for you if there's concern about uterine damage from, let's say, radiation treatment or concern for safety and the ability to carry a pregnancy. And then use of donor eggs. So maybe, it was not in the cards to freeze eggs or embryos. And, you did go into early menopause. What would be an option? Going into menopause does not prevent the uterus from carrying a pregnancy. We can easily give hormones to build up the line. So as long as the pregnancy itself is safe, we can absolutely use donor eggs. So that's using eggs from maybe someone who's younger. There's a number of different ways to do this, but someone who's younger, maybe you could pick someone who looks like you or not. And we can make embryos with a partner sperm, and then we can transfer them back into your uterus. So even if you undergo early menopause, it's still possible to carry a pregnancy. So again, this slide in of itself could probably be hours of discussion, but I think just understanding there's a wide range of options. This may not be for, a lot of these things may not be for everybody, and it's going to be specific to the individual. But again, there's lots of options out there. And then fertility preservation. So I'm going to briefly talk about fertility preservation for men and then treatment options for men post-treatment. So in post-pubertal men, so adult men prior to treatment, sperm freezing is a really good option. It's an easy thing to do. And as long as it can be done prior to chemotherapy, several samples can be frozen, and then that sperm can be used for future fertility treatment down the road. And then, in prepubertal males, so in children, it's a little bit more difficult because obviously they're not able to achieve sperm collection. There is, some data on freezing testicular tissue, but again, more of an experimental option. Okay, and then moving on to post-treatment fertility options in men. So if sperm is impaired, so let's say, a man gets treatment and there's sperm, but it looks, not ideal, but it's still enough to potentially have a spontaneous conception, doing insemination, like I discussed before, may be an option, and that could just be with fresh sperm. The other option is if, let's say there's no sperm frozen from before, but there's a little bit of sperm in the ejaculate, but we don't think it's enough, we can do something called ICSI. And that's actually where you can use a small amount of sperm, and you can basically, here's an egg here. This is just a little pipette that's holding an egg. You can actually put a single sperm. It shows multiple, but you'd only inject one. Take a single sperm with this little pipette and inject it into the egg. So you can overcome a very low sperm count by using ICSI. And I have that here. And then what if there's no sperm? Let's say, there's no sperm in the ejaculate post-treatment. What are the options? Sometimes, so one, if you had frozen sperm, that can absolutely be used to do IVF and use ICSI as I described here. Another option is sometimes when there's no sperm in the ejaculate, there's actually still a small amount of sperm production in the testicle. So there is a procedure, something called TESI, or testicular sperm extraction, where you can actually go into the testicle with a urologist. I don't do this procedure. And you can actually find sperm in the testicle that can be used for ICSI. Again, this would be something to have a consultation with a urologist about, of course, but sometimes we can find sperm. It's not always the case that we're able to find sperm in these scenarios. And then use of donor sperm, so definitely a very viable option as well. Obviously, sometimes different than what people are envisioning going in, but a very viable option for family building. Okay, so we covered a lot of ground there. I'm going to touch on two more things. Hopefully I'll be wrapping up in the next sort of 5-7 minutes or so, and then we can take some questions. So I want to touch on preimplantation genetic testing of embryos for cancer-causing mutations. So we know that our understanding of genetics and cancer is just constantly improving. Obviously, this is a huge field of research. It dictates very sort of patient-specific treatments now. But we know that there's a lot of genetic screening going on in people who are diagnosed with various types of cancer. So there's lots of multifactorial genetic issues that can sort of increase the risk for cancer, but there's a number that are really caused by single gene mutations. So it'll be like a single mutation that we know predisposes. The most common one would be the BRCA1 and BRCA2 genes. These predispose to breast, ovarian, pancreatic, and prostate cancer. Another type is Lynch syndrome, which basically looks at these mismatched repair genes. So again, another single gene abnormality, again, predisposing to a number of different types of cancers. And then I have just another example here of Li-Fraumeni syndrome. But basically, why is this important? Well, obviously, anytime there's a single gene mutation, there's a chance that could be passed on to your offspring. And so, so the question is, are there ways to minimize this risk for children down the road, basically? So how can we do this? Basically, you can see a picture. Again, I've kind of showed you a picture similar that was an egg with the sperm being injected. This is actually at the embryo stage. And what you can do is you can grow out embryos, and then you can do genetic testing on these embryos. So you can basically take a sample of the part of the embryo that's going to become the placenta. So this is the trophectoderm, and they're taking about 5 or 6 cells from that area. We actually know that doesn't damage the embryo, which is pretty amazing. And then you can do a single gene test on that piece of the biopsy to basically see if that embryo is affected with the gene. And then you could decide not to place back embryos that have that gene. So this is, basically you have to make a very specific personalized genetic test. So they actually have to take sort of genetic information from you and a partner, and you would obviously have to know that you carry this single gene. And then they make a very specific, we used to call it a probe, but it's basically they make a little map, and then they use that to test these embryos essentially. They can also do general testing of the embryos, which is something that can always be done. So just saying, hey, is this embryo chromosomally balanced? So it doesn't have Down syndrome, something like that, like it's 46XX and has, or 46XY. So does it have the normal complement of chromosomes? Now, I think it's important to remember, one, this is a really personal decision. So this doesn't mean that you would need to do this, but I think there are individuals that would like to minimize that risk for offspring moving forward. And I think it also is important to note that if you have, depending on the genetic mutation, a decent percentage of these embryos can be impacted. And so we'll eliminate a good number of embryos. So half to a fourth of otherwise normal embryos, and those have to be normal to start with, would be affected if this screening was done. So, I think just knowing that this option is available doesn't mean it's for everyone, doesn't mean you need to do it, but it is something to think about. And then cancer and future pregnancy. So I think, just some considerations prior to conceiving. So you're done with treatment, you're ready to move forward. I think just a really, good conversation with your oncologist. So, I think the things that play into this are the duration of time in remission, what's the role for any adjuvant treatments or longer term treatments, and what's the safety of maybe stopping those sooner to have a pregnancy. And then any specific cancer related risks. So maybe some certain medication side effects are going to pose a higher risk for pregnancy, a chemotherapy that impacts the heart, if there was damage there, well, how is that going to impact pregnancy? Also hormone sensitive tumors, so I'll touch on that a little bit more. I think having really good preconception counseling with an OB/GYN or a subspecialist like myself, so, a reproductive endocrinologist is helpful. Assessing your fertility status, and I sort of discussed this before, but just getting an idea of ovarian reserve or of sperm count before you kind of go into this. And then deciding what treatment makes the most sense. So I think once, you've spoken to your oncologist, and then I think talking to an OB/GYN or a fertility specialist, and then just seeing what makes sense. So even if it's trying on your own, just sort of having a plan and a timeline and doing a basic workup, both to make sure you're healthy to carry a pregnancy and also sort of where things stand in terms of fertility is good. So you can sort of, personalize your plan moving forward. All right, so risks in pregnancy after cancer treatment. So again, like I said, for every part of this discussion, risks are specific to type of cancer and type of treatment. So radiation treatment, there's data to show that chest radiation can impact the heart, and that can have implications during pregnancy. Radiation to the head and spine have been shown to have about a 3-fold increased risk of miscarriage. And then lower abdominal radiation, so impacts on high blood pressure, hypertension, miscarriage, and also preterm or early delivery. What are some other things? Oops, sorry, let me go back one. Surgical management. So for instance, sometimes we will specifically manage different types of cancer, for instance, some gynecologic cancers, by doing sort of treatments that would allow pregnancy. So for instance, in cervical cancer, just sort of removing the whole cervix as opposed to taking out the whole uterus. And that, is going to increase the risk of a preterm delivery. And then also chemotherapy in general. There has been, here are a couple of associations, but some increased risk in preterm deliveries, and then specifically with anthracycline use, some increased cardiac issues. So again, I think these are all very specific. There's ways, for instance, getting an echocardiogram to evaluate the heart beforehand, seeing a high risk OB doctor to say, hey, are these risks for me? I think there's a lot of sort of generalized risks, but it's all going to be individualized. And then I just have like 2 quick slides on breast cancer. I think this is a really common population of patients that we see because there's a lot of reproductive age women who fall into this group. I think that there's a lot of concerns due to hormone sensitivity of many tumors. So, a lot of breast cancers are estrogen receptor, that's ER, or progesterone receptor positive, and safety of pregnancy in women with hormone receptor breast cancer is controversial. Interestingly, the data to date really shows no difference in disease-free survival or overall survival between pregnant and non-pregnant controls. So I think overall the data is reassuring, but of course there's concerns because pregnancy levels are high and sustained for, 10 months, plus during a pregnancy. So again, I think this is an individual discussion and also a comfort level. Your oncologist might say this is okay, but maybe you feel a safer option, or maybe your oncologist feels a safer option would be using a gestational carrier, So I think these are all things to be aware of. And I think, talking to your oncologist about this is important. And then lastly, pregnancy after breast cancer. So again, similar to, I think I talked about sperm exposure to chemotherapy, and in that scenario also, similarly in breast cancer, there's no increased risk of congenital anomalies, single gene disorders, unless of course it's like a note, for instance, you carry the BRCA gene, but no other single gene disorders or chromosomal syndrome. So I think that is reassuring in terms of the quality of the eggs. But there is an increased risk of, preterm delivery, low birth weight. I think these are, again, things to just keep in mind. So we covered a lot of ground, and I know that I'm a fast talker here, but just to kind of recap, so kind of the goals of the discussion today were, one, to understand how cancer and cancer treatment can affect fertility in men and women. And part of understanding that is understanding how normal, reproduction works in men and women. And then also just understanding how and when to assess fertility post-treatment. There's no magic time here. So I think it's, doing serial measurements and kind of proactively monitoring this is good. Describe fertility preservation options, which we went into in a little bit of detail, and then also what are the options post-cancer treatment moving forward. Reviewing the role of preimplantation genetic testing to test embryos for cancer-causing mutations. And then lastly, just discussing a little bit about how cancer may affect future fertility. So thank you all for joining us today, and I'm going to close my screen share, and then we can open this up if anyone has some questions.
Thank you, Dr. Kroener, for that wonderful information. I think it's very important to be shared. So let's go ahead and get started on these questions. The first one we have is from a member saying that her daughter is a leukemia survivor, and she was diagnosed at 5 and in treatment until 7, and now she's 10 years old. Her question is how screens such as iPads could affect my daughter's fertility in the future, and what can be done? What can she do to protect herself? Thank you.
Thanks. So, so in terms of, I think, in terms of screens, I don't know of any data that actually is going to decrease pregnancy rates in the future or fertility moving forward. So I actually haven't seen any convincing data that I'm concerned about, iPad or screen exposure. And I think these are good questions, right? Especially at a very specific time in the world where this has obviously been a really pertinent issue. But I think I wouldn't worry about that. I think it's hard, in younger kids who have had fertility treatment, they haven't gone through puberty yet. And so I think monitoring, just in general, outside of the screen exposure with her pediatrician oncologist to seeing if she starts to go through puberty at a normal time, and then sort of monitoring that is going to be important.
Okay. Another question we have is what treatment options are available for a woman whose period does not return after chemotherapy?
So I think that's a really good question. And I think one is just thinking about the timeline there, so have you reached a point where we know they actually aren't going to resume, so in that early phase, it's still possible that periods may resume. Let's say, in fact, you have gone through early menopause. I think that really at that point, without having frozen eggs or embryos, ultimately the option would be considering using a donor egg. There's also, I didn't even get into this, but options of using donor embryos, because I know that a lot of these treatments can be cost prohibitory. There are also, and I just want to mention this too, there are special programs that do kind of help fund fertility treatments for preservation or post-treatment. And these are probably resources that you can get through your doctor or through a reproductive endocrinologist that can help with that. But unfortunately, I wish this was not the case, we don't have ways to, once someone has become menopausal, and that's truly the case, so you've given your body the time to see if that resumption has happened, we don't have ways to reverse that.
Okay. Another question we have is, my sister had a single mastectomy. Should she be concerned about breastfeeding from her remaining breast?
So I think that would be a discussion I would have with your oncologist, but in general, I don't think that there's increased risk, of breastfeeding and increasing risk of breast cancer in the other breast. But I would have a discussion with your oncologist, or have her have a discussion with her oncologist about that. But again, as far as I know, I don't think so.
Oh, okay. Well, that's good to know. We have a comment actually from one of our members. She said she was 35 when she had chemo for breast cancer and resumed periods in just 6 months post chemo. She got pregnant naturally at 40. I'm a rare case. I am a rare case, I guess.
No, I think that's great. And like I try to emphasize here, I think every person is individual. Like you may have had great reserve to start with, and I think the sooner you resume periods, the better. And a lot of it's really specific to the type of chemo, and part of the, I think part of this is that like, if you're someone who's very fertile, even if reserve is lower, so let's say if I was going to freeze eggs and I can only get two, that's not great for fertility preservation, but you may be someone who releases an egg and you're going to get pregnant really easily. So that's great. And I'm happy to hear that.
Yes, me too. We have chemo made my period regular. Is that a good sign?
So I definitely think that if you have regular periods post-treatment, regular periods are always indicative of ovulating. And so I think that, yes, I mean, I see that only being a positive sign. Obviously we can't really know fully about ovarian reserve until, you would actually do some assessment for that, but I think definitely a good sign.
Oh, okay. And I think attached to that, sorry, it was right under, she said that she has an appointment with an OBGYN coming up. What questions should I ask? I have finished treatment last December.
That's great. So, I mean, it looks like, you're over 6 months out from treatment. So I think really doing a basic assessment, I would do an ultrasound, take a look at your ovarian reserve. So ask them to do an assessment for that. So I'd probably do labs on the 3rd day of your period, do an AMH level and do an ultrasound, and then really think about what and then I think obviously with your oncologist talking about sort of safety moving forward with pregnancy, and then really, this is a discussion I think that's really important. What are your reproductive goals? Would you love to have 3 kids, or is 1 great? And I think those are really important things in dictating how you would move forward. So sort of safety, timeline, and then what are your goals? So you can kind of achieve the things you want, because I guide people very differently, and I'm sure your OBGYN will too, depending on what your ultimate goals are.
It's good. That's good that you mentioned goals, because I've never thought about that either.
Mm-hmm.
Like, what are your reproductive goals? So I think we have time for one more question, and it is there a facility that you would recommend for egg preservation?
So I think there's a lot of good facilities here in Los Angeles. Honestly, I think, if you're from around here, you're lucky enough to have a lot of good options. So honestly, I think the biggest thing is, one, having a doctor that you like and that you can relate to and you have good rapport with. And then I think a facility that has a good reputation, and a good lab. I mean, I think that there's a lot of great options here. One thing I would do is maybe even talk to your oncologist and see who they typically refer people to. I think, obviously I'm biased. I think that, academic centers are a good place for, patients who've had complicated medical histories, just in terms of, egg freezing, but also in terms of, moving forward with, pregnancy in the future. So you definitely plugged into a good system there. So I think those are things to consider when making a decision.
That's great. Well, thank you so much, Dr. Kroener. All this information is awesome. I think it's necessary to be out there. And as a reminder to everybody, this is being recorded, so this will be up on our library in a few weeks. And if not, you can go ahead and watch it immediately on our Facebook page if you'd like to share it with anybody. But thank you again, Dr. Kroener.
Great. Thanks, everybody.